So I'm trained as a physician. I graduated from medical school in 1964 and trained first as an internist and then as a cardiologist, and subsequently became a clinical lipidologist, a cholesterol specialist, and spent most of my career as a preventive cardiologist, working with patients who wanted to learn about nutrition and how to prevent heart disease, and also how to use natural medicine to treat their heart disease. I practiced evidence-based medicine for my whole career, using the medical literature to guide my decisions. And when I became a physician using cannabis as my primary therapeutic modality, I continued to use the medical literature as best I could to guide me in treating my patients. And so what I'm going to want to show you this morning, or it's afternoon now, what I want to show you is how I go about creating a therapeutic protocol for cancer patients. Probably about 98% of the patients that I see now have cancer, and so I have to help them find how to best use the cannabis, and that's what I'm going to show you this morning. I want to answer the question that was asked of Mara earlier first. In 2014, I spent the year in Oakland working in a clinic that provided the medical card. I didn't do any actual treating with the cannabis, but I listened to patients and gave them the card. And I, in Oakland, which has a very large Asian community, I had a lot of Chinese patients come to the office, many who didn't even speak English. They would come with their children who were their translators to get the card. They say, you know, I need the cannabis. And I said, well, what's the problem? And they said, well, I don't know, maybe, you know, it's good in the morning. You know, they never really came up with a medical condition, but it was an herb that they thought was very valuable. And I didn't really understand the relationship of this herb for this population until about 6 months later. I was at a conference and someone was presenting a paper and they showed a slide that had an excerpt from ancient Chinese herbal pharmacopoeia, and cannabis was in that pharmacopoeia, in that herbal medicine catalog, and it was considered one of the higher herbs. So cannabis is herbal medicine, and it is not different from other Chinese herbal medicines. So not only does it treat the condition, but it also, by virtue of the endocannabinoid system, does it heal in a natural way. And there are many people that believe that small doses of cannabinoids can be used in a daily fashion over a lifetime as a preventive. So to answer your question, it not only cures certain conditions or heals certain conditions, but it's also a healing herb and a tonic herb as well, and can be used in that way. You're welcome. So what I'm going to do today is give you the insight on how I go about making the protocol. Okay, so the first thing I do is, let's say I have a patient with neuroblastoma. The first thing I'll do is do a PubMed search, and I'll put in cannabinoid and neuroblastoma and see what shows up. If I put in cannabis, I don't get as many articles to show up as if I put in cannabinoid. If I put in THC, I get even fewer. If I put in CBD, I may get even fewer than that. So the best word I found from experimenting is to use cannabinoid. Now, I think that the National Library of Medicine may have some prejudice towards cannabis, because when I do that search in PubMed, oftentimes it'll come up with no articles. And if I then go to Google Scholar and put in the same search terms that I put into PubMed, I will often get many articles, dozens, even sometimes hundreds, where I got 0 to 1 article in PubMed. So there is a large body of evidence. Most of it is preclinical, but when you don't have good clinical trials to guide you, that's the literature that can be used. That's all you can use, and I use it to the fullest extent possible. So I search in both PubMed and Google Scholar. And it's one of the things to know is that CBD and THC interact at the CB1 receptor, and CBD is a partial antagonist to the CB1 receptor. And so for that reason, I separate out the medicines. I use cultivars like ACDC that are high in CBD, and I use other cultivars that are high in THC, and I usually give a small dose of THC first thing in the morning, the major dose of THC at bedtime so people can sleep through any psychoactivity or intoxication. And there's a trick: if you can take the high dose of THC before you fall asleep and then fall asleep within less than 40 minutes and fall asleep before the THC becomes active, then something changes in your brain. And if you wake up an hour and a half or 2 hours later, you may not have as much intoxication as you would have if you just took it and didn't go to sleep. There's something that changes in the brain once you fall asleep that attenuates or mollifies the full effect of the THC psychoactivity. Now, the ID1 is a gene that is prevalent in young people. Growing cells tend to have higher levels of ID1. Now, as you get older, the ID1 levels go down and may go to 0. But cancers, which are primitive cells that have their own growth parameters, will often have developed this ID1 gene, and it reappears in adults in certain cancers. Now, the thing to know about the ID1 gene is that there's been significant research, primarily at the Pacific Medical Center in the Bay Area, California, in a lab run by Dr. Sean McAllister. And he's identified this ID1 gene and studied it in primarily breast cancer and glioblastoma. And what he's found is that CBD will downregulate the ID1 gene. When the ID1 gene is present, it facilitates tumor growth and metastases. So those cancers which express the ID1 gene are the best candidates for higher dosing on CBD. So what I do to identify those tumors where research has been done and ID1 identified is I put into my search neuroblastoma and ID1. Now, it's crazy, but you have to pay attention to the way ID1 is written. You can get different research if you put ID1 ID1 without a hyphen versus ID1 with a hyphen. So sometimes I do the search with ID1 written in both ways, and we'll come up with different articles. So when I do this search, I know I'm going to use THC most of the time, almost all the time. But I don't know how much CBD I'm going to use, but I do this search primarily in Google Scholar, and if the page lights up with these ID1s in bold all over the page with that tumor, I know that I'm going to use more CBD than THC. If I see no returns for ID1 or one or two papers written, I'll look at those papers and read them and see what kind of association actually exists, and I may or may not give CBD preference in the therapeutic protocol. So ID1, so I then, most of the research has been done with breast cancer and glioblastoma, but I make an extrapolation that if ID1 responds to CBD in glioblastoma and breast cancer, my extrapolation is that if that gene is present in other cancers, there's a high likelihood that it will also respond to CBD, even though it hasn't been studied extensively in the laboratory. So that's my first step in trying to get a handle on how much CBD I'm going to use. Now, there are a lot of tumors that are associated with the human papilloma virus, primarily cervical, uterine cervix cancer, anal cancer, rectal cancer, and head and neck cancer, tongue cancer. All of these cancers have a high association with HPV, which is thought to be causative in developing these cancers. And there is a huge literature that shows that CBD is effective in killing cancer cells that are associated with the human papilloma virus. So if I have a uterine cervix, anal, tongue, head and neck cancer, I'll ask the patient if it's been tested for HPV. And often they know the answer and say, yes, it has HPV. That tells me I'm going to be using more CBD than THC. So for that reason, I came to the conclusion very early that one size does not fit all. There are some purveyors who sell medicine, cannabis medicine, to treat cancer that give everybody a 4-to-1 or a 3-to-1 THC to CBD. Everybody gets the same medicine. And if you look at Rick Simpson, he doesn't make any distinction about the cancer. It's a gram a day, which is a total myth. There's nobody that gets cured in 60 or 90 days with a gram a day, period. It just doesn't happen, in my experience anyway. So one size does not fit all, and I'll show you some evidence to support that in just a second here. So we have to calculate how much, what is going to be the ratio. We have to calculate how many milligrams of cannabinoid are we going to recommend, and then we have to determine what the ratio of those cannabinoids are going to be. So the first determinant is age. As Mara showed you in several of her slides, the younger people can tolerate and require much higher doses of cannabinoids than older people. If you're 75 or 80 years old, it will be usually difficult